Good afternoon, dear colleagues, professors, doctors. Really happy to have everyone here with us this afternoon for our monthly webinar. On this special occasion, we have as our topic medulloblastoma and craniospinal irradiation technique, which will be delivered by our close friend, Professor Jeanette Parks. Along with Professor Parks, we also have local panelists. Together with us this afternoon, we will have Dr. Eko Kuntjoro, consultant radiation oncologist from Kensalas Hospital, Central Java. We will also have Dr. Endang Windiastuti, consultant pediatric oncologist from Cipto Hospital. We have Dr. Ahmad Rafli and Professor Irawan Mangunatmojo, both pediatric neurologists from Cipto Hospital as well. And I think we also have Dr. Reninda Aman, Neuro-Surgeon consultant from Cipto Hospital. Before we start our session, Prof. Tati, do you have several remarks you want to deliver?
Okay, thank you, Ben. Yeah, thank you. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat for all of us. So good afternoon, ladies and gentlemen, my fellow colleague in Indonesia and surroundings, and good afternoon to our distinguished speaker, Professor Jeanette Parks in South Africa. Also welcome to our expert panelists from Indonesia, is already mentioned by Dr. Ben. We have Dr. Eko, Dr. Reninda, Dr. Endang, Dr. Rafli, and Professor Irawan, but also we have Professor Yavuz from Turkey. Thank you very much for being here with us. I feel honored and privileged to welcome you on board in this monthly IROS webinar today. The last time I met Professor Jeanette Parks was in the IEA meeting in Vienna just a couple months ago. We worked together on creating a curriculum for radiation oncology globally. She is a specialist education, as she is a prominent figure also in the field of education in radiation oncology. And we had a chit chat. I was sharing about my organization work, and as she is an expert on pediatric radiotherapy, we had the opportunity to invite her to support as the IROS. IROS is Indonesian Radiation Oncology Society as a speaker in our webinar. She kindly agreed, and we are very honored to have her here today. Currently, Jeanette Parks is the head of radiation oncology and radiation medicine at Groote Schuur Hospital. I hope that I pronounce in the right way. And the University of Cape Town in South Africa, the place that a dream from all of us to have a holiday there, I think, at least for me. And also she is the head of South African colleague for radiation oncology. Now pediatric cancer is becoming increasingly important, especially in the low middle income countries, and also one of the global priorities in cancer control. This is a big challenge for Indonesia, and perhaps Janet in South Africa could relate to many of our situation here. One thing for sure is that cancer treatment requires collaboration with other disciplines. That's the reason why we invite some of friends from other disciplines to be here with us for today. That's as I mentioned, we have Dr. Eko, Reninda, Dr. Endang, but also Dr. Rafli and Professor and also Dr. Yavuz here with us. Thank you for all the participation. That I hope that you can share your experience and perspective in to the floor. I'm really looking forward to a lively discussion session, and that we will gain much insight from Professor Jeanette, and hope we can work together better in the future for our patient. Please enjoy the session, and thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Ben.
Thank you very much, Prof. Tati. Yeah, so colleagues, as usual, our session this afternoon will consist of lecture. For the first 45 minutes, we will have the lecture from Professor Jeanette Parks, and then we will have 15 to 30 minutes of discussion with our panelists. And during the session, please feel free to send your questions to us in written through the chat or question and answer panel, as usual. Before we start, I will continue introducing our speaker for today. Professor Tati has briefly introduced Professor Parks. To add, Professor Parks is currently the president of the College of Radiation Oncology of South Africa. She is also very active in the Pediatric Radiation Oncology Society, or PROS, and also a collaborator within SIOP, which is a major international research group for pediatric cancer. She is also an editor of the IA guideline for pediatric radiation oncology, which will come up really soon. So that will be something very interesting as well. And she acted as PROS area coordinator and now chairperson of the area adaptive management guidelines steering committee. And this afternoon, the topic of the talk will be medulloblastoma and craniospinal irradiation techniques. Professor Parks, thank you very much for coming and welcome. I will hand over the session to you.
Thank you very much for your very kind introduction, Ben and Tati. I'm very privileged to be here today to come and speak to you. So Ben, can you just confirm that you can see my screen properly?
Yes, the screen is okay. Yes. Yeah.
Okay, so we're talking today about medulloblastoma. This is my hospital, Groote Schuur Hospital in Cape Town. The blue arrow that you can see there is the radiation oncology building, and that's where I'm sitting right now. And it's a beautiful kind of spring going on summer type of day here in Cape Town today. So hopefully we'll be able to get some of you over here at some point to come and visit. So I'm talking about medulloblastoma and craniospinal radiotherapy. And this, I wanted to make the point that it's actually less than 100 years since we've even known that this existed as an entity on its own. And Percival Bailey and Harvey Cushing were the guys that first described a mid-cerebellar glioma, usually associated with childhood, and gave it the name of medulloblastoma. And to start off with, it was a surgical disease treated with surgery, and only about 20% of children survived. And nowadays, as you know, we've had various improvements in the treatment of medulloblastoma, so that in high-income countries now about 80% of children will survive. So just a few fast facts about medulloblastoma. It's an embryonal tumor, as I'm sure you know. It constitutes about 15 to 20% of the CNS neoplasms in children. And the peak age incidence is about 4 to 7 years old, with about 70% of children diagnosed before the age of 20. You do get patients in their 20s and their 30s with medulloblastoma, but the disease is rare after the 4th decade. There's a slight male preponderance, 1.7 to 1, and the high-income country literature quotes a metastatic spread in about 35% at the time of presentation. That is much higher in our data, it has to be said. So I imagine it probably would be higher in yours as well. About 80% of these tumors arrive in the midline, in the vermis, whereas about 20% arise more laterally in the cerebellar hemispheres. This disease can disseminate to distant organs, but it usually disseminates via the CSF with leptomeningeal seeding. It was initially put into the broad PNET group in 1973, but we're going to go on to look at some of those pathological classifications. What is in use is the Chang staging. It was widely in use for the staging of medulloblastoma. We know that the size of the tumor doesn't really play a role, but the metastatic staging does. So M0, according to the modified Chang staging, would be no evidence of metastatic disease, where M1 would be a positive CSF cytology on lumbar puncture, done 14 to 21 days after surgery. M2 would be gross metastases within the brain. M3 would be spinal metastases, gross spinal metastases, something like you see here. And M4 is quite rare and quite a late finding, would be metastasis outside the CNS, often to bone. So the presenting signs and symptoms are quite variable. I just wanted to share with you here the Head Smart signs and symptoms. So this was a project introduced by the Nottingham University, trying to highlight the signs and symptoms associated with brain tumors in children amongst the general population, and put forward these symptoms as worrying signs to look out for. And these are almost all of them are signs that medulloblastoma can present as: persistent or recurrent headache, balance and coordination, persistent or recurrent vomiting, abnormal eye movements, blurred or double vision, behavior change, and an abnormal head position or torticollis. Fits or seizures are quite unusual presentations in medulloblastoma. And that presentation is usually fairly acute. So in coming from the New York group, they say that in children under the age of 3, they're usually only present for about 4 weeks prior to the child being diagnosed. The older children, it's a little bit longer, and there's of course an inverse correlation with stage. But some of the data from more low and middle income countries show that our children tend to have a much longer duration of symptoms. For those of you interested in the Head Smart kind of project within, you're looking at creating public awareness about brain tumors, this is the website, and I'd encourage everybody to take a look at it. So the initial imaging for medulloblastoma is usually a CT scan. The children usually present with one of those symptoms I've talked about, with the commonest being headache and vomiting. They're taken into casualty, and this is what the initial CT scan looks like, with these enlarged ventricles and this transependymal fluid shift showing high pressure within the ventricles. So in some centers where MRI is readily available, if this picture is seen, the children would go on immediately to have an MRI scan. But where MRI is not readily available, they would go on to have a contrasted CT scan. So the non-contrasted signs are usually a triventricular hydrocephalus, a hyperdense midline cerebellar mass, and of course, there's always a differential diagnosis, with the commonest being some other kind of tumor like a cerebellar astrocytoma, but those are generally hypodense, and then ependymomas, which are generally isodense. And these tumors usually enhance quite brightly when you give contrast. Sometimes there's large, dense calcifications. The problem with CT is that it's not great for posterior fossa tumors. It can be quite difficult to see small tumors in the posterior fossa. And of course, it may miss the small tumors, and you can't see the leptomeningeal seeding. So usually the patients will go on to have an MRI scan. And this is a typical picture of a medulloblastoma in the posterior fossa, often compressing the fourth ventricle. The enhancement of medulloblastoma can be quite heterogeneous. It's not always just uniformly bright. And most frequently, it's a midline tumor. It can be paramedian, and less commonly a cerebellar hemisphere tumor. But all patients who present with any kind of posterior fossa tumor should have full spinal MRI, full neuraxis staging. And the reason for that is that CSF is not uncommon. As I said earlier, 35% is the figure that's kind of quoted in the high income country literature, but I'm sure this figure is higher. And this can be quite subtle, like you see here, this tiny little nodule in the spinal cord, something a little grosser higher up in the spinal cord, or it can be this sugar coating type of picture that we often see. When we first started doing spinal MRs, we often used to overcall the vascular markings on the spinal MR as sugar coating. So now we require to see them on more than one of the sagittal slices. And of course, you can also see it in the brain. That would be M2 disease. This would be M3 disease. Sometimes you get these big on plaque masses as well in the brain. So the treatment of medulloblastoma is maximal surgical resection, followed by a post-surgical staging and risk stratification. And that is determined by the pre-op imaging of the entire craniospinal axis, the post-operative pathology, then of course the post-op imaging, this should say, and the day 14 to 21 lumbar puncture, which is done for cytology. And the best way to get that cytology is to take the lumbar puncture immediately to we take it to the hematology department where it's spun down to see if there are cells such as this within the CSF. The treatment is then decided on based on this risk stratification, either and it will almost always, unless they're under the age of 3, involve radiotherapy to the craniospinal axis with a boost to the tumor bed, and that should be delivered within 28 to 40 days of surgery with or without chemotherapy. So just a few words about surgery. I'm not a surgeon, but these days we do try to avoid a permanent VP shunt. So usually these children have a drain put in, and this is followed by tumor resection a day or 2 later. And the tumor resection itself relieves the hydrocephalus. The surgical outcomes are determined to some extent by the experience of the surgeon, and the surgery is done via a posterior craniotomy, which looks something like that. So we know that maximal tumor resection improves outcome. This is our neurosurgeon, Prof. Tony Fagaji, busy at work. We call him Batman for reasons I won't go into now, but he's an integral member of our team. And the extent of the surgery definitely impacts the staging, so much so that residual tumor or a certain amount of residual tumor greater than 1.5 centimeters squared, and the squared is because it's measured kind of on a flat screen in 2 dimensions, not 3, is associated with a worse outcome and upstages the patient. So residual tumor of more than 1.5 centimeters squared in the older studies definitely impacted on the outcomes. That may not be true in all molecular subtypes in this day and age, but certainly for those of us that can't do molecular subtyping, that is still true. Of course, neurosurgeons always overestimate their operations. And so the best way of being able to assess that extent of resection is post-operative imaging. Now, this has to be done preferably within 24 hours, definitely within 48 hours. Some of the groups say 72 hours, but the problem is that as you get further away from the time of the operation, it becomes very difficult to tell the difference between blood products and residual tumor. And so the less than 48-hour post-op scan is what gives us the best idea of any residual tumor that's left in the op site. If you cannot get a post-operative scan, and of course it can be difficult because these patients are in ICU, they're often little kids requiring anesthesia, then you will have to use the op note and the planning CT with contrast to assess. The tumor specimen then goes off to the pathologist, and this is the older classification, which just looked at the morphological findings in medulloblastoma and divided them into desmoplastic or nodular medulloblastoma, then medulloblastoma with extensive nodularity, so-called MBEN, and then anaplastic medulloblastoma and large cell medulloblastoma. With most of them being kind of classic medulloblastoma, and we're going to go on to talk about some of these subtypes. So you'll see that there's no doubt that the large cell and anaplastic variants have a much worse prognosis than either classic or the desmoplastic or extensive nodularity medulloblastomas, which tend to do much better. So this was an important distinguishing feature of the morphology. But since about 2007 or 2008, there have been more and more reports about genomics being used to subgroup medulloblastoma, looking at specific genetic alterations and specific molecular variants. And so this chart of 4 distinct subtypes of medulloblastoma was eventually published in about 2010, identifying the Wnt subgroup, the sonic hedgehog subgroup, group 3 and group 4. Now, I know that this has been further subdivided into at least 8 subgroups since that time, but these are still the main 4 subgroups. So these are the 4 that I'm going to talk about today. The WHO 2016 classification then introduced this molecular subtyping also into the classification. So now you were allowed to either classify these patients according to morphology or according to biology. And in fact, they divided them into Wnt activated. The sonic hedgehogs were divided into 2 groups, those that were TP53 mutant and those that were wild type, and then non-Wnt and non-sonic hedgehog group, which constituted group 3 and group 4. And they have quite different characteristics in terms of when they occur, the ages of the children, also in terms of the different mutations and amplifications that are seen. And in terms of their overall survival. So Wnt has a very good prognosis with a 5-year overall survival of about 94%. And group 3 is the worst of the groups with a 5-year overall survival of about 32%. Sonic hedgehog and group 4 are both somewhere in between. Sonic hedgehog consists of those 2 subgroups that I've told you about, with the one group doing very well and the other group doing much more poorly. And since that time, the Sp.A brain tumor group has now defined risk according to a whole lot of different features, which incorporate morphological or histopathological assessment as well as molecular classification in order to classify these patients. And this is what will inform the clinical trials within Europe going forward. So I put this here for interest. It is interesting, but of course, I don't know what happens in Indonesia, but in South Africa, we have very limited availability of molecular subtyping. So what can we do in the LMIC context, and does it matter? Well, we should do the morphology. We should be able to exclude ATRT, teratoid rhabdoid tumors, and ETMR tumors. And then once we know that this is a medulloblastoma, and we do that with INI1 staining, and then we can look at beta-catenin staining, immunohistochemistry, and YAP1 staining. So David Ellison is the pathologist at St. Jude's, and he produced this table, which I think is really helpful for low and middle income countries, just looking at the specific immunohistochemistry findings that you could expect in the different groups. And at the very least, you can divide these patients into Wnt, sonic hedgehog, and non-Wnt, non-sonic hedgehog. So that's really helpful to know. It may not yet change the way that we manage the patients, but I'm sure that it's going to in the future. So for those of us where molecular classification is difficult, immunohistochemistry is a way that we can start to look at these patients. And this is the 2021 classification, where they've now divided that molecular group into Wnt activated, sonic hedgehog activated, TP53 wild type, sonic hedgehog activated, P53 mutant, which is the one that is NMIC amplified, and then non-Wnt, non-sonic hedgehog. And it makes a little mention of the histologically defined medulloblastoma, which is, of course, how we would tend to classify them. I also just wanted to say that there are, of course, specific MRI characteristics which may be associated with the different molecular subtypes and may give us some idea of what is what. I'm not going to go into it now because we don't have a lot of time, but there are specific molecular characteristics. These are 2 articles which are very interesting, just looking at the unique appearances of some of them. So, for example, a Wnt tends to be quite bright shining. It may be centered on V4 or slightly lateralized, but not a cerebellar. Sonic hedgehog may be cerebellar, often very inhomogeneous, looks something like this. Group 3 often has metastatic disease at the time of presentation, and group 4 enhances very little with contrast. So these are some of the characteristics that might be associated. So because we were aware that the treatment of medulloblastoma, both diagnosis, staging, and treatment were different in low and middle income countries through the Pediatric Radiation Oncology Society and SIOP Global Health, we produced a SIOP PODC recommendation. And basically, it's not very different. It says we should avoid a shunt where possible with surgery. We should aim for a small residuum or complete resection, but of course that depends on the ability of the surgeon. Where there's a large amount of tumor left behind, we should consider second look surgery. Radiation, CSI should not start more than 42 days post-surgery, ideally within 28. If it's not possible, 1 to 2 cycles of neoadjuvant chemo is permissible, but it does not take the place of early radiotherapy. You cannot make up for starting late. And then chemotherapy-wise, Alan Davidson and Simon Bailey produced several different regimens which would be acceptable for these patients. We recommended no weekly vincristine during the radiotherapy. That may be reconsidered for high-risk patients, but Amar Gajar felt that it did not add very much to the adjuvant chemotherapy. We tend not to use CCNU containing regimens, and we did not make it a recommendation just because of the difficulty of obtaining CCNU worldwide. And then we tried to limit at least cisplatin, alternating it rather with carboplatin in order to limit ototoxicity. So this is the risk stratification within low and middle income countries. They always quote that about 65 to 75% of kids in USA and Europe sit in this average risk group, and the opposite for the high risk group. But in low middle, when we looked at our statistics, we felt that this was about the opposite. So we have about 65 or 75% of patients in this group. In order to be average risk, you have to have all of these characteristics: a gross total resection of less than 1.5 centimeters squared, and be non-metastatic, and have a classic or nodular or desmoplastic subtype, and have complete staging. Whereas to be in the high risk group, you can have any one of these: residual tumor more than 1.5, or M1 to 3, or large cell anaplastic. There's some concern that the MYC amplified or MYC-N amplified cases should also fit into this high risk group. And then what to do with the incompletely staged patients, or the ones in whom we have a major delay at the current time. Our recommendation has been to put this into the high risk group, but this does depend a little bit on their age and what their histology is. So the outcomes by risk groups across all of the risk groups is fairly good. So the average risk with this approach, we can look at data from the St. Jude group, from the St. Jude Medulloblastoma 96 study, and they found with that approach that we've just discussed now, an average risk outcome progression-free survival of about 83% at 5 years, with the high-risk group about 70%. So even the group with those high-risk features does relatively well if managed correctly. What they did note was that the average risk patients with large cell and anaplastic tumors had a quadruple risk of relapse. And the median time to recurrence was about 24 months for average risk and about 19 months for high risk. So most of these patients, when they relapse, will relapse in the first 2 years and almost definitely by 3 years. This was one of the original studies, just looking at 2 different chemotherapy regimens. This was the PACA group, and showed very little difference when comparing 2 different regimens. And, you know, there's a lot of drugs that work for medulloblastoma and no clear superiority of one drug regimen over another. So even in this trial, what they found was that if you combined average risk craniospinal radiotherapy with adjuvant chemotherapy, any one of these regimens, your 5-year event-free survival is about 81%. So what about high-risk medulloblastoma? Many studies have looked at it. The technique of the craniospinal radiotherapy is not any different, but the dose of the radiotherapy is higher to the craniospinal axis, although the total dose to the tumor bed area is the same. And the chemotherapy can be intensified, although there's not really a standardized approach. And current protocols, research protocols within Europe and North America are looking at different concurrent chemo radiation strategies, as well as maintenance chemotherapy strategies and high dose chemotherapy with stem cell transplant. So I'm not going to really talk too much about those, just to say that. And also to make the point that craniospinal radiotherapy comes at a cost. I'm sure every single one of us that work with children with brain tumors have seen these children who've had craniospinal radiotherapy at a young age and who are really, they can be quite miserable patients. There's a lot of educational difficulty, a lot of neurocognitive decline and residual neurological deficit, endocrine deficits. With the older techniques, quite a lot of alopecia, a lot of endocrine issues, hyperpituitarism, hypothyroidism, primary ovarian failure, poor lung function, cardiovascular events, lots of vascular paths amongst this group, osteopenia, cataracts, short stature, and there's a whole host of others as well. I just wanted to mention a couple of them, just looking at the neurocognitive deficits. And I just wanted to show you that this is the average risk group on the left, the high risk group on the right. This is 6 years old. This is 10 years old, group B. And what you can see is that the average risk group with 23.4 gray are in their craniospinal axis actually do quite a lot better in terms of processing speed, working memory, and broad attention compared to the group, the high risk group that get 36 gray to the craniospinal axis, which is associated with declines in cognitive, academic, social, vocational. So early neurocognitive evaluation is really critical for this group. A connection with the school is really helpful. Remember that these decline over time. So just because the child's okay when they first go back to school doesn't mean it's going to stay that way. And a connection with the family and with the education system is really important. Growth hormone deficiency is also the commonest hormone deficiency that we see in these patients, but of course any of the pituitary hormones can be affected, and they're affected with time. So annual testing of this group is really important. I can tell you I've had phone calls from doctors who are not used to managing children with brain tumors, phoning saying, I've got a child, she's comatose, I'm sure she must have a recurrence. And I go, well, have you checked the cortisol and the thyroid hormone? And they go, oh no, and they phone me back and they say, oh my word, they're 0. And I go, okay, so please replace the cortisol first for a couple of days, then the T4, because otherwise you can put them into a crisis. But there's no recurrence, it's just all hormonal imbalance. Then significant hearing loss is also a real thing. I mean, in our settings, getting cochlear implants is really difficult for these patients. And so it's important that we do everything we can to avoid that ototoxicity where possible. I did just want to show this. I just wanted to mention the group of infant medulloblastoma. It's very important that we look for cancer predisposition syndromes in these children, especially in the M.Bens or the desmoplastic nodular medulloblastoma. We look for Gorlin syndrome, Lee-Fraumeni. And quite extensive testing is done in high-income countries for these groups of patients. And they are divided also into 3 different groups. In the Sp.A groups, this is courtesy of Simon Bailey, who, as you know, runs the infant medulloblastoma protocols for East SIOP. So these are the characteristics of those, and I put them here for your interest, and anyone who wants these slides is welcome to have them. But we won't go into them with detail now. The one group I did want to just highlight are the desmoplastic medulloblastoma and the M.Bens of infancy, less than the age of 2, maybe up to 3. This is a group that potentially may be cured with chemo alone, especially the M.Ben group. Usually in the HIT SKK trials, they received intraventricular methotrexate, and this is ideal. That gives them the best possible outcome, but this is a group that should not necessarily automatically be treated with craniospinal radiotherapy when they reach the age of 3, because they may be cured with chemotherapy alone. And even when you can't cure them with chemotherapy alone, they can be salvaged with craniospinal radiotherapy and surgery at a later stage. So this group of children, watch out for them, the desmoplastic medulloblastoma and the MBEN, the medulloblastoma with extensive nodularity, only within infancy. So now let's talk about radiotherapy issues with medulloblastoma. What's the optimal timing and when should we start? I've alluded to that a little bit. How should we position the patient? Is it better to treat prone or supine? What is the best technique of radiotherapy for the craniospinal irradiation and for the boost? What is the optimal dose of the craniospinal radiotherapy? Do we need to boost the whole posterior fossa? And of course, the burning issue of who follows up these patients. So I have told you that radiotherapy impacts survival. You know, we've looked at different delays in terms of the delivery of craniospinal, because it's really difficult to plan these patients. This is a technique that is very challenging for even the best radiotherapy departments. So they will usually only get these kids 7 to 10 days at the earliest post-operatively. They're often not well the first time we see them, and we have to do their planning scan and then start to plan them so that they're ready by 28 days. That's no small ask, but just so that you are aware, every delay after 28 days impacts on the outcome in these patients. So there seems to be a kind of watershed moment at about 40 or 42 days, but there definitely is a difference as you get time elapsed from the time of surgery in the outcome. Even when you're doing intentional radiotherapy delaying, in other words, you're giving upfront chemo followed by radiotherapy, at least in average risk patients, it affected the outcome. So when you defer your post-operative radiotherapy, even when you give chemo, there's a difference in the outcomes of those patients. This may not be the same for the high risk patients, but it's definitely true for the average risk patients. So now let's talk about the positioning of patients for craniospinal radiotherapy. So in the old days, this is how we positioned the patients. We laid them prone in a cast, try to make them comfortable. The neck was slightly extended like this. There was a junction of 2 lateral head fields with a spinal field. If the child was small enough, they were treated with a single spinal field. If they were bigger, that was with 2 spinal fields. These 2 junctions had to be feathered in order not to risk overlap over the spinal cord and transverse myelitis. And the lateral head fields were treated with a collimator rotation in order to match the beam divergence of the spinal field. So this is what it looked like. We used a block to block the face. And if you didn't extend the chin, you would see that the beam divergence from the spinal field would go through the bottom of the chin. For children that were just a bit bigger than what we could fit into a single spinal field, we also did consider treating with extended SSD up to about 120. After that, the penumbra gets a little bit too blurry to make it advisable. Now, the McGill group, through Carolyn Freeman and William Parker, produced this article in 2006, which is quite an elegant way of doing craniospinal radiotherapy. It described a supine technique where the children are treated usually on a block in order to get skin sparing, something like what do you call it, air equivalent material. So we use polystyrene. The children lie on a polystyrene block, and they still need to be slightly extended. They describe a half beam block with the isocenter at the midline of the inferior border of the head fields, with the spinal ISO placed 20 centimeters below that. They describe this at the level of C2. We find that often exits through the through the chin. And so we prefer to try and make this a little bit lower if possible, but of course you are limited by the shoulders. And there are various different pros and cons of treating supine versus prone. The advantages of supine is that it's much more comfortable for the patient. It minimizes the patient movement because they're more comfortable. It straightens the spine, which is a big thing when you're trying to plan craniospinal. So it's more reproducible. And of course, if you're anesthetizing the child, you get much better airway access. The disadvantage of supine is that you get poor visualization of the field junction. And of course, you also can't treat through the couch if your couch has got hardware in it that is not compatible with a beam going through it. So if you've got metal in your older couch, then you cannot treat in this way. The advantage of prone is the direct visualization of the junction between the cranial and the spinal fields. This can be tricky with supine, so you have to have good imaging as well. But the disadvantages, I think, outweigh the advantages. So we've changed all of our patients now to supine, and it's very unusual for us to treat prone. What is the best technique? So this is a very nice article produced by the Sp.A brain tumor group, radiotherapy working group, just looking at the difference in outcome between, or the difference in technique between 3D conformal radiotherapy, IMRT, VMAT, tomotherapy, and proton beam therapy. So of course, all of them would treat the whole brain and the whole spine. So the advantages tend to be in the way that you can better protect the normal tissue, particularly anterior to your spinal beam. So proton beam therapy is, of course, where you get your Bragg peak stopping right in front of your spine, and you get very little exit dose through your chest and abdominal organs, and that may lead to a decrease, or has been shown to lead to a decreased incidence of secondary malignancy. Of course, if you look at where protons are available, it doesn't, it's not going to work for me or you. Because these are the centers that are in the world, the existing, the ones that are under construction, and the ones that are being planned. So that this is not really an option for us, and we have to look at other techniques. So just a summary of the radiotherapy. It's given within 28 to 42 days. The patients are treated with craniospinal radiotherapy. We're going to talk a little bit about 3D conformal and VMAT. We usually give a dose of 23.4 gray CSI together with chemotherapy to the average risk patients. And then the high risk patients receive 36 gray with adjuvant chemotherapy. The primary site boost gets a total of, it used to be 55.8, but I think even the St. Jude's group, which was using 55.8, has now decreased it to 54 gray. And these days we limit the boost to the tumor bed only with a margin rather than the entire posterior fossa, and I'm going to show you some data on that. So the technique, the clinical target volumes for craniospinal irradiation, we contour the whole brain. It's always easier to use the bone settings. It's more, it's easier to see, and it's more accurate to use the bone settings for contouring the whole brain. You have to contour the whole brain, be sure to cover the cribriform plate, be sure to cover the inferior part of the temporal lobes and the medial part of the temporal lobes, and include any pseudomeningocele, because of course that is full of CSF and therefore can contain cells. Then you add a 0.5 centimeter for the PTV, and note that if you are moving towards IMRT or VMAT, that your contouring technique has to change. But just in terms of deviations, targeting deviations, I just wanted to show you, this is a relatively old study produced by Christian-Kerry from PROS, just looking at the targeting deviations. And the more deviations you have, basically the worse the outcomes of your patient. So very important that you've got some kind of quality assurance and peer review of your target volumes. The places that are the biggest issue are the cribriform plate, so this A group here, and the medial part of the temporal lobes and the inferior part of the temporal lobes. So these are the areas with the greatest number of minor and major deviations. and your outcome is severely affected. This is the relapse rate with 3 major deviations, 78%. So definitely targeting the way that you contour is associated with the outcome. This is a picture that Christian shows in his article, and here you can see the old days, just a manual markup where this little child's crib plate was completely left out. And of course, the cribriform plate is a favorite site for medulloblastoma to recur. The other site that's quite difficult is the inferior part of the fecal sac. So of course, the spinal cord ends at about L1, L2, but the fecal sac, which you can see here on this T2 weighted MRI, goes usually down to about S2, S3. You can see that on the T2 weighted MRI scan, even on a T1 weighted MRI scan, and really we should plan to the inferior border of the fecal sac with a margin, because we can see it these days. The crib plate is important because that's where the olfactory nerve goes from the nerves up into the brain. You can see all these tiny little olfactory nerve roots, and they are bathed in CSF. So when we look at the cribriform plate, this is what it looks like. We have to be very careful that we go far enough down on these frontal lobes that we include this little area here, the cribriform plate, which dips down in between the eyes. It's very nasty because it ups the dose of our lenses substantially, but if you don't include it, you will get recurrences in this area. So this came from an estro course. I thought it was quite interesting, where you can see the index volumes in green and the participants' volumes. Thank you to Sylvia Scoccianti, who showed this exercise at an estro teaching course. But you can see how many people will either go too far forward or don't include it at all, which is problematic. And then, of course, this is what I'm talking about, the pseudomeningocele. It's quite common after posterior fossa craniotomy. You get this bone flap kind of floating in CSF, and this CSF can be filled with cells. So if you are doing the craniospinal, it doesn't have to be included in your boost, but it definitely has to be included in your craniospinal radiotherapy. And then when you're contouring the spine, this is usually what it looks like. So I've already told you we need to go down and look at that inferior border on the MRI. If you don't have an MRI, it must go to the junction of S2 and S3. As it is here, it must include that pseudomeningocele. And of course, if you're looking at the lateral extent of the spinal cord, the spinal cord and the nerve roots are all bathed in CSF. This is the subarachnoid cavity. So the lateral extent of your spinal canal must extend to the lateral border. Your field must extend to the lateral border of your vertebral body in order to include this area that's all bathed in CSF. Again, we don't usually have too much of a problem with 3D conformal because we get a dose bath in that area in any case. But when you move to advanced techniques, you have to be very careful that you are getting what you want in your volumes. So because we don't have to worry, we put on a single spinal field and it exits anteriorly, we're pretty much getting the 20 gray that we know we need to prevent abnormal bone growth in the vertebrae. So we tend to put on an easy margin, which is 1.5 laterally to account for that lateral extension of our the nerve roots coming out of those intervertebral foramina, and we put on 1 centimeter anteriorly and posterior, and that will give us an adequate PTV in order to plan our radiotherapy fields. Just once again, it is not the same for advanced techniques. So if you're changing to advanced techniques, you must read the literature on how you have to tailor your contouring accordingly. So let's talk about the posterior fossa boost. Is the whole posterior fossa boost necessary? So in the old days, this was how we used to contour the entire posterior fossa. We used to have surrogates for the marking when we couldn't use CT on lateral head X-ray to include the whole tentorium and the entire posterior fossa. But you can see if you look at the difference in DVH, there's a massive difference in the total brain irradiation compared to if you treat the whole posterior fossa compared with if you treat the tumor bed boost. So do we need to treat the whole posterior fossa? So this trial was a very important trial which was presented a couple of years ago. at PSYOP the results of COG ACNS 0331, and they asked, in this trial, they asked 2 questions. They asked, can you decrease the dose of craniospinal irradiation to 18 gray in average risk patients? And they randomized all children aged 3 to 7 to between low dose and standard dose. And then there was a further randomization of all the children to either standard volume whole posterior fossa boost or involved field radiotherapy boost. So those were the 2 questions. Can you decrease the CSI to 18 gray? And can you limit the posterior fossa boost to just the tumor bed plus a margin? And there were 2 findings. Finding number 1, decreasing the craniospinal irradiation dose to 18 gray was associated with a statistically significant drop in both event-free survival and overall survival. So the conclusion was that we cannot decrease the craniospinal dose to 18 gray. The second question, the involved field posterior fossa boost was not inferior to the whole posterior fossa radiotherapy with respect to both event-free survival and overall survival. And so that is now standard of care. The conclusion was it is perfectly safe to and better for the patient to use a boost to the tumor bed plus a margin rather than the entire posterior fossa. So posterior fossa boost is now out, even if you're using conformal techniques. Of course, there was some quite interesting information that came out of that session because by the time they were finishing off that trial, they were able to do molecular subtyping, which they had not catered for as part of the structure of the trial. But when they looked at the groups of reduced dose, what they found was the sonic hedgehog group actually did worse with a posterior fossa boost for reasons we don't completely understand, and that this group was the one that was mostly driving this, this outcome. And when we looked at the craniospinal radiotherapy dose of 18 gray versus 23.4 gray, that the reduced dose was most, the reduced outcome was most driven by group 4 subgroup. So of course these are just interesting comments. It wasn't part of the study. It'll need to be studied prospectively, but I thought it was just an interesting nugget of information. So when we do the volumes now for posterior fossa, this is a lateralized one. Often they are centralized on the fourth ventricle here. We can use MRI to help us define where the tumor was preoperatively. It's always helpful to draw that on the preoperative MRI, and then we use the postoperative MRI or the planning CT with contrast to define a tumor bed, to which we add a 1.5, or you can use between 1 and 2. Natia Eseshvili says 1.5 she believes is safe, to the tumor bed to make your CTV, and then you add a margin for PTV, which is, according to your own institution, somewhere between 3 and 5 millimeters, depending on whether you're able to image each day. If you're not able to image every single day, you shouldn't really go below 5 millimeters. So here we are again. Here's our simple technique. This is what it looks like. This is the machine head giving the spinal beam through the bottom of the couch, and there it's lined up against the lateral head fields with its collimator rotation, so that the inferior edge of the field is lined up, and we use this half beam blocked field so that you get a nice flat edge up against the lateral edge of the spinal beam divergence. You do have to feather the junction. So we usually do 3 different plans where the length of our head field is extended by 1 centimeter and 1 centimeter. So here you see the 3 separate lengths of the cranial field, and of course your spinal field is shortened to match up to the edge of the spinal field. So we divide the craniospinal dose into 3, and we shift that junction after a third of the fractions. We do also use for our 3D conformal radiotherapy, we call it, I call it poor man's IMRT, but it's basically forward planning field in field, little contribution fields of 16 monitor units, 10 monitor units, 11 to try and iron out hotspots. Of course, we don't see quite as many hotspots as we used to, because when we lie the patient supine, the spine is much straighter than it is if you're lying the patient prone. And then we like our dose to conform to 95% covering the whole spinal cord. And we use these little top-up fields to help us shape that spinal dose. We also use it in the head fields. If we get hot spots, the famous place for hotspots is anteriorly and posteriorly, and we sometimes use little field-in-field fields with small monitor units to try and iron out those hotspots and make them less hot, to give us better homogeneity. We have used a VMAT posterior fossa boost. So here you can see a patient with a centralized, excuse me, medulloblastoma, and we're treating with VMAT on a Halcyon machine. This is our Halcyon machine, 2 of our RTTs at work here. And then, of course, we have to combine our VMAT plan with our 3D conformal craniospinal axis plan to be able to see exactly what's being given to all the organs at risk. It's very important to have good verification of your spinal field matching, whether you've got 1 or 2 spinal fields, you're matching to the cranial fields, and it's really important to have good quality assurance on your machine, good imaging, and that it's checked correctly by the right people. So that feathering is changed. You can create anterior setup fields, which are used as a surrogate for the matching posteriorly, because of course you can't see the back of the child because he or she is lying on it and the beam's coming up from underneath the machine. So you need kind of dummy fields drawn onto the anterior part of the patient in order to check your daily setup. And then you have to image the patients. So I just wanted to talk a little bit about the Sp.A brain tumor group consensus guideline about high precision radiotherapy. This is a really good article produced by this group, just showing you the differences that you have to start to concentrate on if you do decide that you're going to move to VMAT or IMRT craniospinal radiotherapy. Basically, with 3D conformal radiotherapy, your patient's whole brain and spine will be bathed in radiotherapy, and they may be dosed to areas that you are getting without contouring them. That is not the same when you move to an advanced technique. If you don't contour it, it won't be treated because the computer won't know to look for that area and give it radiation. So when you move to VMAT, please take a look at this article. Remember that you have to include all your cranial nerves, all of the foramina, the optic nerves, they're all bathed in CSF, and they have to be included in your volume. And you must also take a very careful look at the most inferior part of the temporal lobes, the pit fossa, the full length of both optic nerves, and then these base of skull foramina, which are also full of CSF, as you see there with the white signal around the 7th, 8th nerve complex there. So we decided we were going to transition from 3D conformal to VMAT. This is an article which has actually just been accepted for publication in the South African Journal of Oncology. And a shout out to our group of physicists and my colleague, Dr. Naika, who have sort of pioneered this by looking back at the last 10 cases and doing retrospective planning of all of the cases before we moved to live patients. So understanding your target is key. This is what I pointed out, all these little foramina along the base of the skull. Probably these ones are not too much of a problem, but these ones, foramen ovale, foramen rotundum, the superior orbital fissure, the cribriform plate, these all need to be contoured when you move to advanced techniques. You also need to get doses on all of your organs at risk. So it's important that you know how to contour all the organs at risk so that you can get dose volume histogram information about each of the organs. So we contour, this is a patient that's contoured for everything because it was an exercise. Of course, you can't really protect, you can't assign a constraint to the hippocampus because you don't want to protect that area in these children, but you do want to make sure there's no hot spots sitting in these very sensitive areas. It really helps when you are contouring to use MRI, which is fused to your planning CT if you have that available. There's also a great atlas available online from the RTOG for the contouring of the hippocampi. And then the vertebrae are very important. So for example, if you're using protons, you have to be very careful now to properly contour all of the growing elements of the vertebrae so that you don't get eccentric radiation of your vertebrae and get a kyphoscoliosis in these patients. So you have to outline the vertebrae in this way if you're going to move on to craniospinal radiotherapy. So what we found was that we got much better sparing of our midline structures with the VMAT. Kind of this is what you're looking at. I was very worried that because you spread out the dose that you would get a much worse lung dose, but I'm going to show you some of those parameters in a moment. But you do get less exit dose through your bowel in the front, through your heart and your lungs. So this is what it looks like. You use 3 different isocenters with a 10 centimeter overlap. So your junctions become less of an issue, but it is a very complicated plan. We use sort of modified partial half arcs like this that come from both sides. And this is the type of plan that you can get. Very complicated. If we look at, so in this particular plan, Turindri opted not to outline each vertebra independently, but to check the 20 gray isodose line and make sure that that is properly covering the whole vertebrae in order to prevent that eccentric growth and the kyphoscoliosis. So that's what she did there. And here you can see much better sparing of the heart and the lungs when you spread out this dose with those partial half arcs. So this is what we found. These were the organs at risk. This is absorbed dose. If you look at the green, it's IMRT. If you look at the blue, it's VMAT. And if you look at the yellow, it's 3D conformal. So the real benefit for moving to VMAT sits in these structures here, your parotids, your thyroid, your esophagus, your lungs. There was very little difference. I expected this would be worse because you're not just getting a single posterior beam anymore. You're kind of spreading out that beam and you're getting more lateral dose, but it really wasn't much different. And the heart was significantly more in the 3D conformal radiotherapy. For these structures, it really didn't make much difference. The spleen was actually a bit better, as you would expect, in 3D conformal, and then the kidneys, it was more or less the same, maybe very slightly increased dose for the IMRT and the VMAT because the dose is spread out a little bit. So that was a very interesting exercise for us. You can see, for the brain and the spine, there's not a lot of difference. You're treating the whole brain and the whole spine, but the difference comes here in this body radiotherapy. And particularly when you start to look at these high doses here, the price you pay for that is the low dose, increased integral dose that we see with the advanced techniques. And although that was a huge concern 20 years ago when we first started using RMRT, those concerns about an increased incidence of secondary malignancy due to low dose areas and an increased integral dose haven't really played out in the literature with the use of VMAT and RMRT. So I think most departments that do pediatric radiotherapy will use RMRT or VMAT rather than use 3D conformal if it's available. Of course, the time is different. It takes a lot more contouring. So if your rad-onc is your limiting step, then that can be a problem. Of course, there are software packages now that can do a lot of the organ at risk contouring using artificial intelligence. So that I think will be the way that a lot of the low and middle income countries will move in the future, and hopefully there'll be some cost-effective software that's available for that. But for the actual planning, it takes less time. The beam delivery per fraction is a little bit longer than for the 3D conformal, but not too problematic for the children. So all in all, we felt that it was a really good a good exercise, and we will move all of our patients now to VMAT craniospinal. But I must just emphasize that you must have strong physics and very carefully look at those changes that are required in terms of your contouring and in terms of your quality assurance before you attempt to move to advanced techniques for craniospinal radiotherapy. Advanced techniques for the boost is a different story. So just by way of conclusion, treatment has not really changed that much over the past decades for medulloblastoma, not yet. Definitely the best outcomes are obtained when you have a multidisciplinary team looking after the child both before treatment and after. Proper staging is critical. The child must receive surgery, craniospinal radiotherapy timelessly, and adjuvant chemotherapy. There's good survival outcomes, at least in high-income countries, with average risk achieving 80 to 85%. It's not quite that in our hands, but not that far off. And even the high-risk patients do relatively well with cure rates or 5-year survival rates of 60 to 70%. There's been tremendous progress in the understanding of the underlying biology of medulloblastoma, and I've got no doubt that this will inform trials in the years to come. The clinical trials now look at the feasibility of integrating those molecular subgroups into the risk stratification and tailoring therapy based on this new stratification. And the management beyond the acute treatment of all of these things is, of course, paramount and very much relies on that multidisciplinary team and the ability of the team to provide a long-term follow-up for these children. So I thought this would just be interesting, just as a last slide. Ahmad is the head of pediatric oncology at St. Jude's. And this is just the new risk stratification under their new study, SJMB12, where they look at basically a lower dose of radiotherapy for the Wnt group. They look at the addition of targeted chemotherapy like smoothing inhibitors to the sonic hedgehog group, who might have specific targets that are that they've got drugs that can target. And then this non-Wnt, non-sonic hedgehog group, the addition of novel chemotherapy, especially for the group 3 group, the very high risk group, which does particularly badly. So this is probably how the risk groups will be defined in the future. We looked at our medulloblastoma in our department, and we've managed to show, whether this is stage migration or whether it's due to improvements in imaging or radiotherapy or surgery or chemo or all of the above. I don't know, but I can tell you that in our latest decade of patients, we've managed to improve the outcome of our entire group of patients, of which 2/3 were high risk, to very close to what is seen in those high income countries. So I think we can all take some pride in those kinds of outcomes. So a few thank yous from my side. I would just like to thank, this is Reninda, who is a consultant in our group, and she does the pediatric CNS and sarcoma patients together with me. This was on Childhood Cancer Day in October. And then these are some of our RTTs, our medical physicists, when we got our new Halcyon machine. And then this is our combined MDT, our neurosurgeon, our pathologist, our pediatric radiologist, our pediatric oncologist, and then our another neurosurgeon who does some of the cannulation of the retinal artery for medulloblastoma, as well as the base of skull surgery. So that's our group. I've also used some slides from Nati Esiashvili from PROS, and I thank her for the use of those slides. And thank you very much for the invitation to speak today.
Thank you very much, Professor Parks. Very insightful presentation. We have gained a lot of new information there. Very useful. Before we address the questions from the audience, I would like to invite our panelists today to share some perspective of their experience in the various aspects in the management of medulloblastoma. I think we should start with the diagnosis, and maybe while we at it, also address the long-term follow-up aspect of these patients. And for this, I would like to invite either Dr. Ahmad Rafli or Professor Irawan to share some experience?
We only try to discussion about the neurological cognitive. Is it okay? Not by the slide. Okay. Okay, thank you for your awesome and comprehensive explanation, Prof. Jeanette, and also IROS, Prof. Tati, Dr. Mayang, and teams who invited us to sharing our experience in the field of pediatric neurology. In our Pediatric Neurology Center, Dr. Cipto Mangunkusumo, Jakarta, Indonesia, from 2019 until 2021, we have maybe 20 children with medulloblastoma. And some children come to our center with increase intracranial pressure. Some children with tumor in the midline have gait ataxia, whereas some children with tumor in the lateral cerebral hemisphere have limb clumsiness or incoordination. Dizziness and double vision are also common symptoms of our patient. As we know, medulloblastoma can interfere our quality of life and also in children growth development in our children. Its component of treatment can cause delay complication that have a profound effect on quality of life and longevity in medulloblastoma children, particularly those patients diagnosed and treated childhood and adolescent. Although the late effect of the treatment on quality of life are often attributed to craniospinal radiation therapy, chemotherapy has a significant role in aggravating the adverse effect of radiation therapy. In our center, we suggest to parents, especially after their children undergo therapy, to regular visit to our clinic, pediatric neurology clinic, because we would like to assess some complication like for the first, maybe we know posterior fossa syndrome, which is called cerebral cognitive affecting syndrome or cerebral mutism. That can be seen in approximately 1/10 of our patients who came to our clinic. This complication is characterized by impaired language production associated with emotional ability. The symptoms frequently improve over the course of weeks to months, but some children may not fully recover language skill for months or years. And another complication that we should consider is maybe neurocognitive impairment, as you explained before, which is commonly observed following multimodality treatment for medulloblastoma, particularly in young children, and disease can be severe. And the risk factor for increased severity of long-term deficit include younger age, higher risk disease, and radiation dose. And the most commonly observed deficit in our patient and our center are in process speed, attention, and working memory. We do neurophysiological examination and also neurophysiologic and also neurocognitive are recommended in all children with medulloblastoma to monitor for cognitive function in our child. And we should ensure that our children have good growth and development. So in this part, we pediatric neurology must overcome this issue by therapy and sometimes coordination with physical rehabilitation or physiatric teams, and also do assessment regularly to our patient, especially cognitive function. Prof. Irawan, do you have any additional information about this issue before maybe I continue with our perspective, Prof. Irawan, please?
No, thank you.
Okay, and maybe for Prof. Jeanette, do you have any suggestion based on your experience to reduce this complication, especially in children? And do you have like special teams to monitor the patient and children with the medulloblastoma to ensure for the growth and development of our children? Thank you very
much. Specifically talking to posterior fossa syndrome or cerebellar mutism. So I think this is a complication that happens even in the best hands of our neurosurgeons. Our neurosurgeons tell us that it is a little bit operator dependent, especially for those centralized tumors, that the way that the cerebellum is approached and the way that the retraction is done at the time of surgery does have an effect on the way that on the outcomes of those children. So you can reduce cerebellar mutism in that way, but it is really catastrophic when it does happen, and there's not a lot you can really do about it. What you shouldn't do in these patients is delay their craniospinal radiotherapy, because the cerebellar mutism gets better But if you miss the boat in terms of the timing of the radiotherapy, that affects the prognosis of the patient. So the cerebellum mutism does tend to get better, and I'm not sure that there's a lot that you can do about it. The long-term neurocognitive, I mean, one of the, as we've seen better and better outcomes, we've seen, obviously all the things you describe are real, the endocrine issues, the educational issues. So we've got an educational psychologist that does an early assessment of the children and liaises with the school, the teachers and the parents. So outlines what is possible for this child, tries to make sure that the child gets remedial support from quite early on, physiotherapy for some of the actual neurological signs that you talk about, the ataxia and the incoordination. And then the other big issue that's been quite a buzzword at the moment is sort of hyperactivity and behavioral disorders in these children. And there's been quite a lot of literature and a few studies starting to look at the effects of Ritalin. I don't know if you call it Ritalin, but it's used for attention deficit disorder in these children, and that there might be some advantages to early interventions using this medication in those children. But I think the jury's still out on that, but certainly it is something that's being considered.
And do you have any special team to monitor this patient also too in the Cape Town also?
So we in terms of so we see them usually every 3 months for the first year, every 6 months for up to 2 years, and then every year thereafter. We do their endocrine bloods at least once a year. We don't, the big issue for these kids, as it is for other pediatric malignancies, is there isn't really a mechanism within the adult system to refer them to. So once they are 5 or 10 years after radiotherapy, there's not an adult neurology service to refer these children into, or doctors that will really look after them. So we have got a pediatric brain tumor follow-up clinic, late effects clinic, but we have kids up to, I say kids, up to 40, 45 in that clinic because they've got nowhere else to go. And because other doctors don't necessarily understand what late effects they are prone to. We've also started to see some of them getting secondary, not always malignancies, but secondary brain tumors like meningiomas. There's quite a high incidence of children that do get those. And so we've started to scan their brains. Once they're 5 years out, we pretty much think they're cured unless they're desmoplastic. And then we scan every 5 years to look for meningiomas and treat them quite soon. And we also intervene with the endocrinologists if we start to see osteopenia, that kind of thing.
Okay, thank you, Prof. Jeanette, for your suggestion. Thank you, Dr. Gregorius, for our perspective from pediatric neurologists.
Thank you, Dr. Rafli. We touched upon cerebellar mutism, and I think this has a lot to do with surgery as well, which brings us very nicely to the next step in the management, which is surgery. So, Dr. Ananda, is there anything you would like to share about the neurosurgical aspect of medulloblastoma management in Indonesia?
Thank you very much, Dr. Ben. Thank you, Professor Parks, for your comprehensive talk. I'm sure we have learned a lot. I did learn a lot during your talk. And our department has been a part of the team that required that we do and we treat the patients as a multidisciplinary team. And for neurosurgeons, that our task is to take the mass out safely, maximum safe resection, and from the tumor that we can establish the definite pathology, and then we can be sure that if it's a medulloblastoma or not. Because of the location of the mass that obstructs the CSF, then usually the patient have hydrocephalus, and has to be treated or diversed to reduce the intracranial pressure. Usually we do that intraoperatively. We do a ventriculostomy and we drain the CSF partially, not all, but partially, in order to make the brain relax and do the fossa posterior surgery or craniotomy, a transfemoral approach. We cut the femurs and then we take the tumor out safely. Of course, there are some tumors sometimes attached to the brainstem and also cannot be taken from the cerebral tissue. That's why the residual tumor has to be treated, of course, with adjuvant therapy. Regarding cerebral mutism, most patients experience cerebral mutism. And as you know, that we don't know really what was the cause, probably because of the separation of the vermis or the transvermilion approach. That is one of the causes of the cerebral mutism. And sometimes the medulloblastoma is very vascular, and during surgery you have to give transfusion, blood transfusion. And of course, as a surgeon, we have to decide whether to proceed or stop the surgery to save the patient and to have a post-operative care that is beneficial for the patient. Because what is the purpose of the surgery if you take the tumor out, but the patient doesn't survive? So, and we know now that medulloblastoma needs a multi-modality approach. That means that we have to remove the tumor much as possible and do the adjuvant therapy, radiation, and chemotherapy. From our experience, the patients usually have the symptoms of increased intracranial pressure. And with toddlers, sometimes they don't complain about headaches, but always fall down. And then the patients usually treated by the pediatrician and then referred to us to do the surgery. And once the pathology is confirmed medulloblastoma, then our team will decide when we do the adjuvant therapy, the radiotherapy or the chemotherapy. Of course, the differential diagnosis of medulloblastoma before surgery, there is a pilocytic astrocytomas or ependinomas, but usually the radioimaging sometimes is quite similar. And afterwards, after the surgery, then we can conclude that this is medulloblastoma, then the adjuvant therapy can be given. As a whole, our team is a very good team. We communicate every week, every Friday. We discuss patients, and we are glad we have a good team. And again, Professor Pas, thank you for your comprehensive talk in this webinar or keynote series. Thank you.
Thank you, Dr. Nanda. I have two questions, actually, something that we might want to think about. There is a good practice for post-op imaging in medulloblastoma, and this requires us to do, well, ideally it should be MRI, and it should be within 48 hours of the surgery. Do you think this is something we can incorporate in our routine workflow of medulloblastoma patients? And the second question is about centralization of surgical procedures. Do you think this is something that will make a difference in terms of achievement, gross removal of the tumor? Or is this something that has more to do with late presentation of the patients?
Thank you, Dr. Ben, for the questions. For the first question, Of course, it depends on the logistic, but the more simple and more practical way we do CT scans after surgery, because that's the best way to detect postoperative bleeding. And also you can give contrast to see if there is any residue. So what we do here in practice, that we do 48 hours postoperatively. Rarely we do MRI, but after 1 month, usually we do the MRI, where we can see more clearly if there is residue and cerebral edema has been subsided and the hydrocephalus has been released. And the second question is whether to take the tumor out. Our concept is maximum safe resection for all patients in neuro-oncology, also in pediatric neuro-oncology. So, of course, it's the mechanical cytoreduction that has to be achieved is to leave a small remnant, if not possible, complete resection. But the patient must survive the surgery. As you know, I mean, in our hospital, 40 years ago, nearly all patients can survive the surgery because of surgery itself or postoperative care. But nowadays, at least the patient will survive the surgery and will continue the adjuvant therapy. Thank you, Ben.
Thank you very much, Dr. Nanda. Right. Professor Parks or Professor Anichak? I know you're there. I know you're there, Professor Anichak. Hello.
Hello.
Yeah. Would you like to add anything to our discussion so far? Your experience in Turkey?
Yes, thank you very much. I was not prepared for a talk, but thank you very much. And I think it was a very nice talk. Medulloblastoma, it's not a common tumor in Turkey, but we see a lot of patients because we have a lot of children as well. The technique we are using in Turkey is different. There are very few centers are doing medulloblastoma and craniospinal irradiation. And just a couple of days ago, we were discussing who is doing what among us. And some centers still use conventional technique, not because of they don't have the capability to apply VMAT or other rotational techniques, but because of the fear of the integral dose to other organs. Some centers prefer that to reduce the dose to heart, lung, and spinal, lung and other critical organs. And there are some centers who is doing tomotherapy as well. We have some more than 10 centers of tomotherapy, and some of them are using using it for craniospinal irradiation. So the technique varies. For example, in our department, we are still using the conventional technique because we still don't know with the VMAT or other rotational techniques the effect of the lower dose to other organs in the kids. But we use craniospinal, but then we use some segments as well. So some kind of modified technique, and boost the cranial with VMAT. So we use modified according to our needs. So it depends. And we of course all of us use the chemotherapy and lower dose spinal dose. And this is thank you very much for this wonderful panel, because craniospinal radiotherapy, I think it's the most difficult of all techniques in radiotherapy. And I believe if a center is doing a good craniospinal irradiation, that center can do any other technique in radiotherapy, because there is everything: long fields, narrow fields, junctions, toxicity, children. There is everything on it. Thanks. for that.
Thank you very much. I have a question on that aspect, but I will do it later. So stay with us. I will ask this question to you and Professor Parks later after we're done with the round with the panelists. Thank you very much. So I'll move on to Dr. Eko Kuntjoro, radiation oncologist from Central Java, to share some perspectives on how medulloblastoma is managed with radiotherapy. Dr. Eko?
Okay, thank you, Dr. Ben. Thank you for Prof. Jeanette. Your lecture is very complete. So very, very wonderful. And also Prof. Dr. Rafli, Prof. Panelists, also Dr. Reninda also told us about the program in the department. In Semarang, Central Java, we haven't any FIMET now, but maybe Prof. Tati the next time will ask to the Minister of Health so we can complete our machine. 20 years ago, we did it with 2D technique with cobalt-60 with SSD only 80 centimeter. So it is no contouring. We just only use a conventional simulator. Yeah, but now we do it IMRT and 3D conformal. But I prefer, as I told before, I prefer to do it 3D conformal because we have large load of patient. With 3D conformal, we must contour about 2 hours every patient. Yeah. So it's time consuming. The second, I told our experience in our center, we always, because of the survival is long enough, yeah, 9 years or 10 years for standard risk. So we must explain to the parents of patient that after radiation therapy will be many defects. As cannot talk very well, and someday something very stupid, the child will be stupid, but because we told him that the risk if not irradiated, so they agree to their children to get irradiation therapy. Yeah, I will ask Professor Jeanette, how in your experience, how many patients who get secondary malignancy with FIMET? Thank you.
Yeah, I don't have an absolute figure on that. So you know, I have managed that long-term follow-up clinic for pediatric brain tumors for about 20 to 25 years, and probably during that time I can remember seeing about 3 patients with malignant tumors, of which 1 was a glioblastoma and 2 were sarcomas. But I've seen about 5 patients with meningiomas, multiple meningiomas, and one of them had actually died of a grade 2 or 3 meningioma. Had meningiomas all over the cranial vault and down the spine as well. Was irradiated at the age of 12, and she was about 40 when she was diagnosed with those meningiomas. So I think meningiomas are commoner, but in terms of an exact incidence, I don't have those figures to hand, I'm afraid.
Yeah, thank you. For you have explained us that posterior fossa is not entirely irradiated with modern technique, but only to the tumor. So I think we need after surgery, we need to make an MR so we can see about the residue, about the debris of the after surgery, and we can focus on the tumor bed. Yeah, thank you.
Can I make a comment, Ben? So I know when we move to post-operative MRI, it's difficult because the kids are usually in ICU and they often need an anesthetic. So it's quite an undertaking to do post-operative MRI, but it does give you that information about the extent of the resection. But our neurosurgeon always makes the point that if he had to choose a group of patients in whom it makes the biggest difference, he would choose ependymoma patients because the extent of the resection is definitely associated with, you know, the recurrence rates and the prognosis in that group of patients, even more so than with medulloblastoma. So I just wanted to make that point. I also think that in years to come, once we are able to do biological and molecular testing, there might be groups of patients like the WNT group, for instance. We know that total resection might not be as important as it is for the other groups. So this might inform how we manage the patients more than just in terms of their radiotherapy and their chemotherapy, but also in terms of their surgery in years to come.
Okay, thank you, Dr. Ben.
May I have a comment? Well, from the radiation oncology point of view, whether the tumor is totally resected or not, I think it doesn't matter too much, because in any case, we will give the booster dose, and if there is a microscopic tumor or total tumor totally removed, there is not too much difference in the dose and the field as well as for us. It changes, of course, the risk of the patient, but for radiation oncology, it doesn't too much change if there's a residue in the end or not. I don't know what you think about Jeanette.
Well, it depends on how much is there, Yavuz, because according to our kind of risk classification, if you've got significant residual, then you will treat to full dose craniospinal, 36 gray. So in terms of the volumes, it doesn't make a huge difference, but it does change your risk.
Yeah, but we don't see, I don't remember any case who the surgeon cannot remove and most of the tumor. There are sometimes very small, well, medulloblastoma surgery is relatively easier than the other, let's say, some of the other tumors.
I don't know. We see patients that are referred from outlying hospitals and areas where we've had surgeons that have operated on the patients that are not used to, firstly, children, and secondly, medulloblastoma, and will do a resection where there's less than 50% of the tumor removed, and then the neurosurgeons have to go back in and do a repeat resection. So that is not a very unusual scenario for us if the patients are coming from sites that are not used to treating pediatric malignancies. So I'm interested to hear you say that you don't see that. You must I don't know, either your referrals are different or you've got centralized services, but certainly throughout Africa, where we've got very limited numbers of pediatric neurosurgeons, we often see that.
No, yeah, you are right. In case of a rare resection, there is always much tricky.
Thank you. Interesting discussion.
Yeah,
we also see a lot of this problem with incomplete resections with a lot of residuals, especially when the patient is from other hospitals, private hospitals usually. Dr. Eko, you were saying something?
Okay. In my center, until now, we will push all of posterior fossa. Yeah. Thank you, Dr. Ben. Thank you, Prof. Jeanette. Prof. Yavuz, thank you.
Thank you. I think we should move on to the next part of the management. We have Dr. Endang. So Dr. Endang, we have touched upon the diagnosis, the surgical aspect, the radiotherapy aspect briefly. And I think we also would like to know to what extent is systemic therapy contributing at this point, and which regimen is considered most appropriate for Indonesian children?
Thank you, Ben. Thank you, Prof. Jeanette, for the very nice talk. I learned a lot from your presentation. So about the medulloblastoma in hospital, usually the patient first comes to the division of pediatric neurology because of the symptoms made. And chemotherapy usually after surgical, after the radiation, then come to us. And unfortunately, usually the division of pediatric hematology or oncology left behind, I feel, because sometimes I hope that we have a good team, right? Like Dr. Reninda mentioned, but I feel that please involve us before the surgery or before the radio treatment so we can follow from the beginning. Usually patients come to us when the neurology division start because the patient is already in the good condition and also have the metastasis. We have the protocol for that, but the effect of the immunosuppressive in the young child, in the child less than 5 years, still have acute morbidity such as immunosuppressive effect, infection, and then the electrolyte imbalance, and then because we also have carbo or cisplatin, we have to check the ototoxicity. We have a good correlation with the ENT Achmad, and also sometimes the nephrotoxicity or neurotoxicity. But I have 2 patients with the non-metastatic medulloblastoma, and I think it's already stopped for 3 or 4 years. 2 patients, one of the son of our college, now in the good condition, can go to school. I think they don't have any problem in cognitive neuropsychology. So, but I want to ask for Prof. Jeanette is about one of the studies show that the reduced craniospinal therapy followed by the chemotherapy have also the outcome, the event-free survival rate around 80%, if I'm mistaken, but 60% still have progress disease because they have a component of dissemination, also the secondary malignancy. That's what I want to ask. And about the chemotherapy pre-operative, maybe one of the research also show that the chemotherapy pre-operative has some benefit, like make it's easy complete for removal and also have impact on the neuropsychological outcome, I think. But that's all I want to ask about the reduced cranial radiation followed by the chemotherapy.
So let me talk to the second question first. So just in terms of that PACA series, so the problem is there's never actually been a study which has looked at craniospinal radiotherapy by itself and craniospinal radiotherapy with chemotherapy. So the one trial that there was closed early, and it showed inferiority of radiotherapy alone. But when they did the long-term follow-up of that study, actually those two curves came together and there was no difference between them. So, but I think that what generally people seem to believe and not have any doubt in is that when you do treat reduced dose craniospinal with adjuvant chemotherapy, that those for that average risk group that you're looking at survival rates of about 80% plus at 5 years. So you can give craniospinal radiotherapy on its own in that group as well without adjuvant chemotherapy. But if you don't give 36 gray, the outcomes are inferior. So if you're not giving the chemotherapy, then you can't give reduced dose craniospinal and you have to give 36 gray. And then the neurocognitive outcomes, I think, are worse. So for sure, you do have these issues with side effects from the chemotherapy as well. But personally, I think that 36 gray craniospinal radiotherapy on its own is, I would not choose that for an average risk child. I would rather give the reduced dose craniospinal with adjuvant chemotherapy. I'm not sure if that answers your question. I wasn't, maybe I didn't hear quite perfectly, but the other question was about pre-operative chemotherapy. So I think that the problem with this group of children is they usually present very acutely with hydrocephalus. And so it's not really possible to do pre-operative chemotherapy. That's why I think mostly the management of these children has been to do the surgery, remove the tumor, relieve the obstruction, and then give the further treatment, whether that is chemotherapy or radiotherapy. So the high risk patients, there have been some studies of chemo before radiotherapy, and you know, I think the jury's still out on that for the high risk group, but definitely in the average risk group, if you delay the radiotherapy, you get inferior outcomes.
Okay, thank you. How about the second malignancy after the finish all the treatment for the medulloblastoma?
Yeah, so you know, the secondary malignancies. So I must say, you know, in terms of leukemias and stuff like that, the sort of hematological malignancies, you know, we've got a huge clinic that we've followed up for years and years. And I don't think I can. I think I can remember one kid in all of the time that we've treated brain tumors that has developed a hematological malignancy. We don't see a lot of those. What we have seen is some solid tumors, the ones that I said, a couple of sarcomas, one GBM, and then these meningiomas, which are not your common old garden grade 1 easy to resect meningiomas. They're difficult. They tend to be a higher grade. They tend to be multiple. They tend to be in different places. You never know which one's going to grow. So usually we manage those quite conservatively, and we manage them by treating only the one that's causing a problem at the moment, because you just don't know which one's going to grow. But the hematological malignancies, is that what you're meaning?
Yeah.
I can't recall really seeing any number of those.
Okay. Okay. Thank you, Janet. Okay, Ben.
Thank you very much, Dr. Endang. But I think you raised a very important issue here, which is multidisciplinary coordination as early as possible. And what you're saying is completely true. It is also very uncertain for us when we decide on the technique and dose for a patient, what technique to use, what volume to deliver to, and what dose to give, when we don't know whether the patient will be sent for chemotherapy or not. And this usually is true when we have referrals from outside the city, patients from far away. Sometimes their parents just drop out. I mean, after finishing radiotherapy, they don't even return for the 2-week follow-up. So this is something, this is a big homework for all of us, I think. Thank you very much for raising this issue. And as Professor Parks mentioned, the radiotherapy technique will depend on the systemic therapy being planned or delivered. So we have seen a lot of publications about dose reduction, about smaller volumes, but these have to be seen in package with the adjuvant chemotherapy that is delivered. I think this is a very important message for my radiation oncology colleagues as well. Thank you very much. So now that we have gone through the multidisciplinary spectrum, I think it's time for us to visit the question and answer panel. We have 3 questions so far. Let's go from the first one. Okay, so we have a question about the craniospinal technique, and the question was whether it is possible to split the cranial and spinal part. I hope I'm understanding this correctly.
Split it in time or split it in terms of the volume. So it's very difficult.
To be split in terms of time. That's what my impression from this question anyway.
So I think it's very, very difficult to match fields if you're not planning them at the same time. So I think it's much safer to plan and treat at the same time with craniospinal. Every now and again, especially if there has been a delay in the planning, which does happen from time to time, and when it does happen, we do give chemotherapy before we start the craniospinal. Very occasionally in those patients, we do see issues with the blood counts. And then we can have some problems if you continue to treat, especially with the platelets, if they've had carboplatin, if they are receiving the craniospinal radiotherapy. So if you're getting platelets of less than 20 and you have to rest the patient, I don't rest them completely. I usually continue with the boost on those days, and then continue with the actual craniospinal radiotherapy. But I've never separated the cranial and the spinal radiotherapy. Yeah,
I think that's very important as well. But you raised also an interesting point. It is also sometimes practiced that the boost is delivered before the craniospinal part. What do you think about this?
Look, that's not, I don't think that is standard. The standard treatments usually give the craniospinal before the boost, but I don't think in average risk disease, you know, if there's an option to deliver the boost before the craniospinal, then I guess you could go ahead with that. The problem with it is that the reason the craniospinal's not ready to go is usually because it hasn't been planned. And the boost and the craniospinal affect the total gray. And so you should really have the whole plan available to look at before you actually start. So I think that it's a little bit of a risk to start the boost before you've completed the planning of the craniospinal.
Thank you. Yeah, and by common I meant not in the literature, but in practice here in our country.
Yeah, in practice, I do sometimes continue with the boost, but only if I'm having issues with the blood counts usually.
Thank you. So I hope that answers the question, Dr. Nuraini. I'll move on to the next question. This one from Jakarta about 2 patients which had spinal MRI with lumbar puncture as well, negative for both examinations. Hold on, I need to rotate my phone. Okay, so negative disease before radiotherapy, but with residual disease. Dr. Eko, are you able to unmute yourself and ask the question directly?
I can read it if you like.
Yeah, sure. Am I understanding this correctly? Okay, so
Ben, I think I can understand what they're asking. So he's saying if that he had 2 patients with an MRI spine and a lumbar puncture, and the spine and the lumbar puncture were negative, but there was residual disease post-op. We did craniospinal radiotherapy of 23 Gray and a booster at the local tumor up to 54 Gray. And we had a complete response, a 6-week MRI, the follow-up 3 months and 3 months again was clear. But after about 6 months, there was recurrence in the spine. The local control was still excellent. I would like to see if there's something I missed. So, so Eko, it is, you know, unfortunately, you do get some patients that are going to recur. Theoretically, if you've got residual disease post-op that hasn't been removed and it's more than 1.5 centimeters squared, then that would be high risk that you would treat with 36 Gray. But in your particular patient, it seems like your patient has got a problem of distant relapse in the spine and not local relapse. So it may just be bad biology. But usually that residual of 1.5 centimeters squared on post-operative imaging would put you into that high-risk category. I must say, I feel very uncomfortable treating children under the age of 5 with more than 23.4 Gray these days. I almost never do it, even if they're high risk. I do it with some discussion with the parents, just because the neurocognitive outcome is so much better that I'm prepared to accept a slightly higher risk. So it does depend on the age of the child as well. So I hope that answers your question. It's probably bad biology.
Thank you very much. The third question was about optimal timing for CT and MRI after surgery. I think you addressed this earlier.
So we do that immediate post-op MRI, which helps us decide on the staging of the patient and the further treatment. And then we do an end of treatment scan, which we tend to do 3 months after the end of the radiotherapy to allow all those kind of inflammatory changes to die down. So we do our post-treatment scan either 3 months after the end of the radiotherapy or at the end of the adjuvant chemotherapy. That's our end of treatment scan that we use as our baseline scan to compare other scans to going forward. And then we didn't used to do surveillance scans for medulloblastoma, just because recurrent disease is really bad news for these patients. Most of them will succumb to recurrent disease, unlike ependymoma. So we didn't used to do it, but now there are some instances where you can treat recurrent disease successfully in medulloblastoma. So now we tend to do a scan at 6 months and then an annual scan for the first 2 years. And then we stop doing scans and we scan every 5 years after 2 years, just to look for other things like meningiomas, but not for recurrence.
Thank you very much. There was a question in the chat. If the tumor extends inferiorly to the spinal cord level, do you still give 54 Gray there?
So that's an interesting one. So yes, I mean, it depends on where the tumor went. I always make the point. So I don't like to treat the brain stem, especially in younger children, to more than about 54 Gray, but I will treat the upper cervical part of the cord up to about 54 Gray. I won't go above that. But it's unusual for medulloblastomas to go out beyond foramen magnum. It's much more common with ependymoma, which those you're trying to treat to 59.4 Gray, so it's even more of a problem. So then I usually limit the brainstem and spinal cord to 54, but I will go to 54.
Thank you very much. We have a new question in the Q&A. We did this. One was, when is the best time to check for CSF for diagnostic workup? And second, which chemotherapy would you suggest for infant medulloblastoma in LMICs? There is no stem cell rescue yet in Indonesia. Okay, and she completely agreed with Dr. Endang about the need for early MDT. So when's the best time for CSF diagnostic workup, and second, chemotherapy regimen for infant medulloblastoma in LMIC?
So, so the best time to do a lumbar puncture is 14 to 21 days post-operatively. It doesn't carry the same significance if you do a cisternal puncture at the time of surgery, because a lot of the surgeons do cisternal punctures after they relieve the pressure at surgery. They do a cisternal puncture and they get CSF at surgery. But the implications of positive cisternal CSF is not the same as the implications of the lumbar puncture CSF at 14 to 21 days. So that's the best time to do that lumbar puncture, is at 14 to 21 days post-operatively. Having said that, I must tell you that when we looked at our cases, M1 disease or CSF positivity, actually those cases we did treat with a higher dose, but they didn't do worse than the M0. The M2s and 3s definitely do worse, if you can see it. But I think there's still some questions about the implications of CSF positivity. But it should be done at 14 to 21 days.
Great, thank you very much. I have one question about advanced techniques for craniospinal. You described IMRT and VMAT for the craniospinal part. And I think you mentioned that the spinal part was given partial arcs. So in this technique, how do you manage your junction? I mean, for conventional and 3D, you use moving junctions to feather. But what about when you inverse plan?
So the great thing about VMAT is that you don't really have a junction. You have a 10 centimeter overlap of your field with 3 different kind of, you have multiple ISOs. And that's the part where your medical physics is so important, because you have to check your multiple ISOs on your machine. But because you get that, the leaves kind of overlapping like that over such a long kind of length, 10 centimeters at each overlap, it's not a problem. You don't have the same risk of that overlap where you're going to get double dose. I don't know if I'm explaining very clearly.
Yeah. So the worst case scenario is actually for a certain voxel to receive high intensity from both beams for all fractions. But I understand that this is very hypothetical, and in reality, this will be mostly random, right? Is that the assumption?
Sorry, I missed that, Ben. I didn't hear it all.
Yeah, basically when you use IMRT or VMAT, there will be differences in intensity levels between voxels. And the worst case scenario that we usually are worried about is that certain voxels overlap, receiving high intensity. Let's say 2 voxels with a distance of 2 millimeters, both were supposed to receive high intensity. And then because of setup uncertainties, they become overlapping. So worst case scenario is that now you have a voxel with double your intended dose, but I assume this will be mostly random, right?
Yeah, look, this is a problem for the medical physicists, but this is why you can't just move to this technique without having intense medical physicist input, because firstly, all the planning is inverse, so it's not intuitive, and secondly, they have to prove that what you plan is what you actually get on the patients, and they have to prove that your machine hardware is working as it should be, so that you're not getting those overlaps. So I think what you say is correct, but I think that this is exactly why it's not that easy to just move to VMAT. You have to have a lot of medical physics input.
Thank you. Now, moving slightly backwards, you also described field and field technique, right? 3D with field and field technique to increase the homogeneity of the dose distribution, both for the cranial and spinal field. Now, that also raises the same question about how you manage your junction. Do you do your junction first, and then for each plan you do field and field? Am I assuming things correctly?
Yeah, so we do the field in field, and then you're just changing the length of the cranial and the spinal field. So you almost do like 3 different plans, and then you total gray them. So for those 3 plans, they will have different lengths of the cranial field and the spinal field, and then the junction. So the junction will move by about 1 centimeter on each of those 3 plans. So you usually will divide the total craniospinal dose, whether it's 23.4 or 36 gray, in between 7 and 9 fractions per plan, and then add those 3 plans together, and then add your boost at the end. But your field in field on your spine is probably going to be the same for all those 3 plans because it's lower down.
Right, thank you so much. Do we have other questions? I think we can accept one more question if anyone still has any burning questions in their hands, both from the panelists and also from participants.
If there is no more, I think it's already the time then. It's already more.
Okay, thank you very much. Okay, Prof. Thank you for closing. So yeah, with that, I would like to thank everyone for participating in our monthly session, especially to our speaker, Professor Jeanette Parks, and also to all our panelists. Thank you very much for sharing your knowledge and experience to us. And also to the participants for the excellent questions and discussion. We hope that our session today was useful. So before we officially close, Prof. Tati, is there anything you would like to add? Or
no, just I'm very happy because the discussion is very strong. Hope that everything will give a benefit to our patient, especially our patient for the medulloblastoma. You know that Jeanette already mentioned that the peak is about 4 to 5 years old, right, Jeanette? So we have to take care of them carefully. Thank you, Jeanette. Thank you, everybody.
Thank you very much. So everyone have a good evening, and Jeanette, have a nice day. Thank you so much for sharing.
Bye.
Thank you. Bye-bye. Bye-bye, everyone.
Bye. Thank you.
Thank you very much for
Bye.
Bye. Leave.